done traditionally by technologists is now being completed by the radiologist due to the advanced technology of imaging that we have nowadays. So you may not be even doing these in your department. Some of you will, okay, but not all of you. So what I'll be going over here are the overhead projections of the esophagram. So when you get the room set up and you prep your patient accordingly, you're going to put the patient or the table in an upright position. Okay? It's going to be in an upright position with the footboard secure, the patient secure. Doctor comes in and he's going to do his fluoroscopic study, watching the patient swallow from the oral pharynx down until it reaches the stomach. The patient will be standing in different positions. Patient generally holds the cup on their right hand. Okay? They'll drink. Doctor observes. They'll go in a different position. Drink. Doctor observes. And he'll snap his photos or pictures. We call them spot films. Have you guys heard those terms before? Okay? The doctor will take his or her spot films accordingly. Upright, different positions. And then, doctor leaves the room, and then you start your overheads. So for the overheads, there are three basic projections. It's an RAO, a lateral. Okay, the lateral is generally a right lateral, not just because it has nothing to do with anatomy. It's more of the way the rooms are set up. Okay, so it's usually a right lateral. And lastly, it's going to be an AP projection. So those are your three basic views for an esophagram. So the first one that we're going to cover here is an RAO esophagram, RAO. And although the doctor does the study in an upright position, we as technologists usually do it in a recumbent position. They're laying down. In an upright position, the doctor during fluoroscopy can easily follow and track the contrast as they are swallowing it. We can't track that down while they're standing up. Okay? It moves through their esophagus a lot faster. So when they're laying down, it is a better fill. The contrast doesn't empty as quickly when they are laying down. So we do it recumbent. So we'll place them in an RAO position like so. Cup's going to be held on their left hand. Right arm is going to be down by their side. Their left knee is going to be slightly bent for support to hold them up. So the rotation is anywhere between 35 to 40 degrees. And the whole purpose of that is trying to get the esophagus away from what? The spine. So your esophagus and your spine are superimposed. So if you rotate them, it removes superimposition. Okay? The patient's going to be rotated 35 to 40 degrees. You're going to use a large image receptor and collimate to an area of about 7 by 17. 7 by 17. It's just like this. Okay, because your esophagus is just like this. So we want the full length of 17, but we're going to collimate side to side approximately 7 inches. Center ray is going to be directed at the level of T5, T6, which is 2 to 3 inches below the jugular notch. Or you put the top of your image receptor or your light field 2 inches above the shoulders. Okay? So you can do either way. You can center at T5, T6, or put the top of the cassette at 2 inches above the shoulders and then line up your tube to your image receptor. Now, because the patient is rotated, you're not going to center mid-sagittally. You're going to center 1 inch from the spine on the upside, so towards the left side. So 1 inch from the spine to the left. We want short exposure times. Remember, the patient's going to be drinking, so we want a quick exposure time to snap a good image while they're swallowing. Okay? Now this is the way it's going to go. So you give them the cup of barium with a straw. You're going to tell them to start drinking. So Miss Jones, in a minute here, I'm going to start taking some pictures of your esophagus. What I want you to do is I want you to continue drinking. I'm going to tell you to drink and swallow, drink and swallow, drink and swallow. And you continue to drink. Don't stop until I tell you to stop. Do you understand that, Miss Jones? She'll say, okay. All right. So now this is what you're doing. You're going to get a head start. Patient's on the table here. All right, Miss Jones, go ahead and start drinking. Drink and swallow, drink and swallow, drink and swallow, drink and swallow. Boom. Hit your exposure switch. Okay? Exposure is usually done between 3 to 5 swallows. Okay, that's a good feel of the esophagus. Okay? There's no breath hold. It is continuous drink and swallow, and you hit that exposure switch anywhere between 3 to 5 swallows. Now, what are you going to tell them? You need to tell them to stop. Remember, it's just like holding your breath. If you don't tell them to breathe, they're going to continue to hold their breath. So you need to tell them to stop drinking, otherwise they're going to keep chugging that thing down. Okay? Okay, stop drinking. Now, that's with the thin barium. If the doctor chooses to use the thick barium, okay, remember the one that has a consistency of like oatmeal. They are going to take 3 spoonfuls of the thick barium, okay, and on the 3rd swallow, you're going to step out of the room and you're going to tell them to hold their breath and then hit the switch. Okay? Drinking, okay, the drinking, there is no holding of the breath. The thicker barium, okay, you're going to have them hold their breath. And on the 3rd swallow, you're going to be back there and you're going to hit that switch. Okay, it's going to be done immediately. Any questions? So drinking, they can drink, they're breathing. The thicker barium, they're going to have to hold their breath on the 3rd swallow. Okay? Any questions on RAO? All right. Left lateral. No, I'm sorry. Right lateral. I just said we don't do. Okay, we do a right lateral because, why? Because the patient is facing us. If they're doing left lateral, we can't see them. So right lateral, based on how the room is set up. So right lateral. Same thing. You can either center at T5, T6, or put the image receptor about 2 inches above the shoulders. All right? And you're also going to do this at mid-coronal plane. Mid-coronal plane. Patient's going to roll up on their side. Again, important position. Not only are you going to roll up on their side, you want to make sure they're straight up and down on the table. And they're not crooked, but they're straight up and down on the table. So you're going to do an evaluation from the top of the table, from the bottom of the table. Make sure that they're properly aligned. Okay? Image receptor collimation, again, 7 by 17. We're looking at the tube. You don't need a lot of, you don't need a lot of the beam to be in there. The esophagus is very narrow. Okay? So they're laying on their side, legs slightly bent, one on top of the other, keeps their balance. Arm in front of them like they're praying. Okay? Again, maintains the balance. Assist them by putting the straw in their mouth. Okay, here we go, Miss Jones. Are you ready to go? Okay, drink and swallow, drink and swallow, drink and swallow, drink and swallow. Boom. Okay, stop drinking. Got it? All right. Any questions so far? Next one here is the optional swimmer's lateral. So now you get somebody who is very broad-shouldered or might be overweight, slightly obese. Okay? If you're trying to shoot through a thick shoulder, you're not going to see the proximal portion of the esophagus. So what we're going to have them do is have them roll their shoulder back just slightly. Because I'm just trying to get rid of this mass, and now I'm going to shoot the esophagus right through the chest. Okay? This is the optional swimmer's lateral. Same thing applies, okay? So so what you're going to do now is you're going to center just slightly about an inch and a half off the mid-sagittal plane. So what you're going to do here is find the mid-sagittal plane and center about 1.5 inches on the upside. It's kind of like, it's almost like that RAO. This is almost like an LPO, you guys agree? So from the mid-sagittal plane, you're going to center about an inch and a half off that mid-sagittal plane. Okay? Same level, T5, T6, so put the top of the cassette image receptor 2 inches above the shoulder. And again, drink and swallow. Okay? Make the exposure. Okay? And then last one here is the AP. We still do APs, although we try to get as many views as possible, but you are going to get superimposition of the spine, but it completes the study. So again, 7 by 17, T5, T6, or the top of the image receptor 2 inches above the shoulder. Okay. Now, this is where it gets a little sketchy, okay? Make sure that the arm is out of the way when they're drinking. There shouldn't be any arm in the way when they're holding that cup, so make sure it's out of the way. Okay? Out of the way. Questions? See, she has hair ornaments.
And earrings.
And earrings. Yeah, I would have had to remove that earring.
She has hair and ear ornament.
All right. We're done with esophagram. Let's do upper GI. You guys ready? All right. Now remember what I said. These procedures can be done separately, but sometimes they can be done as a grouping. So it's very common when you're doing an upper GI, you're also looking at the esophagus and also the proximal part of the small bowel. Sometimes the doctor may order an upper GI and a small bowel, okay, because it's continuous. So they drink the contrast. Their stomach fills up, they do the examination, and now they wait for the contrast to move around their small bowel, and now we take abdominal images of the small bowel. Okay? So there may be multiple procedures that you can do together. So, upper GI, the preparation is going to be a little bit more involved. So, you do your history, you ask your questions, the whole thing about have you had anything to eat or drink, da-da-da-da-da. Okay, so let's just say now we've asked all our questions, we've got our patient prepped, they're wearing the correct gown, all jewelry, all artifacts have been removed. Now, what you're going to do now is you're going to prep the patient by giving them something to drink before the doctor comes in. All right? So you're going to have your contrast, the barium. Okay? You're going to have your gas crystals. You guys follow me so far? Okay, because it's a double contrast study. You're going to have your barium, you're going to have your gas crystals ready to go. So, these are the instructions. You usually, in the radiology department, you're going to have plastic shot glasses available. They're like 10 cc shot glasses. Okay, it's kind of like the same cups that you see when you're drinking NyQuil, those little cups. Okay, you're going to have those in your department. You're going to fill up that small cup, it's anywhere between 5 to 10 cc's depending on what your protocol is in your hospital. You're going to fill that small cup up with barium. Okay? And in the other cup, you're going to dump all the gas crystals in the other small cup. You guys follow so far? Now you're going to give the crystals, the first thing you're going to give them is the gas crystals. And before you have them take the gas crystals, this is what I used to tell them. Miss Jones, here are some gas crystals. It's going to fill up your stomach up with air. Now, what I'm going to have you do is I'm going to have you throw that in the back of your throat. Okay? And then I'm going to have you wash it down with this barium. Okay? Do you understand? I understand. Okay. So they throw it back. Okay? Then they wash it down. But I forgot a step. You got to tell them, you're going to feel like you're going to want to burp. It's important that you don't burp. Okay? So do this. But. So now you have to do it again. Okay? Because if they burp, they don't have the air in there, you have to do it again. So you got to make sure that they follow those instructions very, very carefully, okay?
Can we tape their mouth? No.
It's just going to come out their nose. Have you guys ever burped through your nose? Yeah. Okay.
Girls don't do that.
Yeah. So, you eat hair. So throw the gas crystals, wash it down with a contrast, okay? Now, here's the next step. You're going to have them get on the table. Okay? Have them lay on their back for a few seconds. Then you have them lay on their right side for a few seconds. Then you have them lay on their belly for a few seconds. And then you have them lay on their left side for... You see what I'm doing? What am I doing?
Coating
I'm coating up the stomach. Okay? So they're going to be rolling around on the table. And then once they make full rotation, now you get on the phone and call your radiologist. We're ready for you in room 3 for the upper GI. That's your prep.
So during all this rolling on table, she doesn't burp?
She should not.
So...
Do they? Yes, they do. Okay? But we've given them enough gas crystals that even if they burp a little bit, there still should be some gas in there. Okay? But if it's a really loud belch, then we need to give them some more. Okay? So now that you've rotated and coated the stomach, now you call your doctor. Doctor, we're ready for you in upper GI, room 3. They'll do the fluoroscopic study. They may have the patient drink the contrast, some more contrast during the procedure. Your responsibility while the patient is moving around is to make sure that they don't get tangled up in anything. And be sure to get whatever the doctor wants, more contrast, towels, whatever. Just be ready to assist them, okay? So, again, patient's going to be rolling around different directions. Doctor's taking his spot films. When he's done, when he or she is done, now you're going to do your overheads. These are the overheads. Okay? Ready? All right. So these are all the stuff that we just talked about. Is this on your slides?
Left side.
Okay, I mean the previous slides, right? Barium, straw cups, napkin towels, gas crystals. Double contrast is good for detecting polyps. I said all that, right? I said all that. Okay. Hair ornaments. Shielding. Okay. So these are your basic views for an upper GI. You have RAO, PA, right lateral, LPO, and AP. Do these seem familiar? We covered parts of this in the esophagram. Okay, so almost the same positioning criteria. So the first one here is an RAO. The RAO. So again, we're going to oblique them 40 to 70 degrees obliquity. Right arm down by their side, left side in front of them to help support their weight. Legs slightly bent to also maintain that balance. What size image receptor are we going to use here?
14 by 17.
We don't. The stomach's only about this big.
10 by 12.
Okay. Remember, you guys remember, your stomach is as big as what? Should be as big as your fist, right? All right. So we're going to use a 10 by 12. Collimate to an area of 10 by 12 or 11 by 14. So those are your common collimation sizes. So 10 by 12 or 11 by 14. Now, do you have to get that exact collimation size? No. But it's a starting point. Okay, because we're dealing with digital imaging now. So all we're saying is just collimate to the area of interest, 10 by 12 or 11 by 14. Okay? Now, what you should have been doing while the doctor was performing that fluoroscopic procedure is keeping a close eye, is keeping a close eye on the viewing monitor to see where the stomach was. Because that's going to be your clue in where to position the image receptor. So if you were watching closely to where the fluoroscopic unit was in taking images of the stomach, that's where your image receptor should be in positioning for the stomach. And if not, again, aesthetic, if they are aesthetic, the stomach is usually at the level of the elbow, kind of like the gallbladder. But we'll cover that here in just a second. So oblique the patient 40 to 70 degrees. Here's some catches, okay? There was something here about rotation. Okay, so this is kind of jumping around. Let me do this first. Okay, so centering for the upper GI. Centering for the upper GI is going to be midway between the xiphoid tip and the lower margin of the ribs. That's the level of L1. There are other ways to find L1. You can also do, what you can also do is after you collimated your area to a 10 by 12, you place the bottom of your light field at the top of the crest. But again, that depends on your body habitus. So you got your light field on your patient, okay? You got your light field on the patient. You move the light field at the level of the iliac crest, okay? Or one hand span from the top of the crest. This is where your center is going to be. It's another way to do that. Or center at the level of the bent elbow. Are these exact rules? No, because why? Because of body habitus. Okay, this is just a starting point. And you have to adjust accordingly to the body habitus. Okay? So the patient's rotated 40 to 70 degrees, less for aesthetic, more for hyperstenic. Center at the level of L1. Again, I just put one criteria up there, 2 inches above the lower lateral rib margin. I think that's the way your book has it listed. To find L1, you're going to do 2 inches above the lower lateral rib margin. Lower lateral rib margin. So you go feel for the ribs. Okay, the bottom of the rib cage, and then you're going to go 2 inches from the bottom of the rib cage. And then midway between the spine and the upside lateral border, which is the left side. Okay? Why are we going towards the left? Why not the right? Because the stomach's on the left. Okay? And I've seen this often. For some reason or another, when the patient's on prone position, you guys, the students, get confused where the anatomy is, and you start centering for the stomach on the right side. Because it's the patient's right, but it's the table's left. Does that make sense? So you're positioning over here on the right side, going towards the left side of the table, and that's why they do it. So remember, when they're prone, the left now is on the right side of the table. Okay? All right. Now, once you position, what are you going to tell your patient to do? Do we want them to continue breathing? Oh my God, we only had a winter break, right? We've only gone like a year. What are we going to tell them to do? Hold your breath, okay? Don't tell them to take a deep breath in, okay? Just hold your breath, okay? Because the moment that they take a deep breath in, what happens to your diaphragm? And then what's going to happen to your stomach? It's also going to drop. So just have them hold their breath. We don't want the location of the stomach to change. Okay? All right. The pylorus and the pyloric bulb and the C-loop is best demonstrated in the RAO position. RAO position. That is a test question. So how do we know they're in RAO position? Remember the Scotty dogs? Well, they're starting to look like rabbits now. Okay. So they're just pointing on the side of rotation, right? So this is an RAO. Remember the orientation of the stomach. It goes from the top, it starts in the back, and then as it makes its way to the body and the pylorus, it goes anteriorly. So they're laying semi-ly on their belly, so the contrast is going to end up here in the body, in the pyloric region. air rising to the posterior, okay, and that's the fundus. Can you guys see some of the rugae going on there? The ruga? Kind of see it. This patient needs more air. They burped it out. Okay, this is a little bit better. You can really see the rugae here. All right, so the entire stomach and duodenum is demonstrated. The body and the pylorus are filled with barium. And I put this up here for you guys so you can put that on your notes too. And air is in the fundus, in the RAO position. And I put this up here too for you guys as reference. So I will give you, I'll upload the new version for you guys. As we said, the RAO is good for the duodenal bulb, and the C loop is also in profile. So you're starting the C loop right here. Starting to show up, proximal portion of the small bowel. In fact, I mean, the stomach emptied up pretty quickly that you're seeing the jejunum in there as well, right? Here's the jejunum. There's a feathery look to it. And then here's the ileum right here. So duodenum is up here. Jejunum is mostly on the left side, on the upper quadrant, and more centrally is going to be the ileum. We'll cover that next week. All right. Here is a PA for the stomach, no rotation. Central ray, again, is at the level of L1. So you can use any of those techniques to find L1. Xiphoid process, you can use the rib margin, you can use the cassette, placing it on top of the crest, as long as you know how to find L1. Okay? Now, in a PA, I cleaned this up a little bit because the way it looked like before it was very confusing. So, in a PA, you're going to use a small collimation field of 10 by 12 or 11 by 14. Okay? If a small bowel is part of the upper GI, we're not just looking at the stomach, we want to look at the stomach and the rest of the abdomen, so you're going to use a 14 by 17. If it's just an upper GI, this is what we're going to use. Okay, the small image receptor. If you want to include the entire abdomen for a small bowel series, now we're looking at stomach and small bowel, you want to use the larger image receptor. Okay, I'm going to stay with the first bullet point for just a little bit. You guys understand that? So if it's just the stomach, small image receptor. If I want to look at the stomach and the entire abdomen, I'm going to use the larger image receptor. That makes sense, right? Central ray is going to be at the level of L1 and 1 inch to the left of the midline if we are using the smaller image receptor because we're just looking at the stomach. So to look at just the stomach, 1 inch to the left of the midline at the level of L1. And if it's a 14 by 17, a larger film, now it's going to be, you're going to set it 2 inches above the crest, 2 inches above the crest, and mid-sagittal plane. And that's what this patient is positioned here for right now. She's positioned for a large image, 14 by 17, 2 inches above the crest. Now, why do we do PA instead of AP? We do APs, but why would PA be better?
It's the variant to the
Was I-
pyloric region.
Well, yeah, because the stomach is more anterior, so it gets it closer to the image receptor. But
It squeezes, like spreads it.
exactly. So when you're on your belly, it spreads the bowels. So everything is not so convoluted. It spreads it out for better visualization of the bowel segments. Okay? It compresses it. Okay, so the entire stomach should be demonstrated. Now they're on their belly. Contrast is going to go to the lowest point. So if they're face down, contrast is going to end up at the body and the pylorus, right? And air is going to rise towards the most posterior part, which is the fundus. Okay, so body in the pylorus has the barium, and air is in the fundus. Oh, it's already up there, and I did it twice. I didn't see that. Okay. And then we have the right lateral. Patient is in the right lateral. True lateral. So again, it's all the same level. It's always at the level of L1. Okay? So the patient's on the right side, arms bent, legs bent, center at the level of L1. There was a typo in the previous slide. It said at the level of the lower rib margin. Is that what it said on your slide? It says, I think it said CR to L1, but it says at the level of the lateral rib margin.
Lower lateral margin.
Okay, it's 1 inch above. So so tack that on. 1 inch above the lower lateral rib margin. And then 1 inch anterior to the mid coronal plane. Mid-coronal plane. Now, this is also good to note, is that the stomach does move slightly higher on a lateral. So use that as your guide, but you may want to move up just a little bit more from your starting point. Okay, so the stomach is slightly higher in the lateral. And then, here's another test question. The lateral best demonstrates the area behind the stomach, the retrogastric space is well demonstrated in the lateral. So you're seeing the area behind the stomach, retrogastric space. It's good for that. So the entire stomach and the duodenum are demonstrated. So is the retrogastric space. So here we have the fundus, we have the body, the pyloric region, the pyloric bulb. What is this area right here? What is that? Duodenum. Okay, and then you see the rest of the small bowel starting to fill up as well. And then we have an LPO. An LPO. Patients rotated 30 to 60 degrees obliquity. More rotation if they're hyperstenic, less if they are hypo. Criteria for central ray doesn't change. Again, it's at the level of L1. L1, L1, L1. Okay, so 10 by 12, 11 by 14. At the level of L1, astenic 30 degrees, hyperstenic 60 degrees. And so once you get the level of L1, now you're going to center slightly to the left of the mid-sagittal plane. Okay, because where's the stomach? It's on the left side. So you're going to center slightly to the left of the mid-sagittal plane. At the level of L1. And now that they're on their back, where is the contrast going to end up?
At the top.
Yeah, and on the back, so it's going to end up right here, on the fundus. There it is. Contrast in the fundus, air in the body, because it's more interior, the body and the pyloric region. And then an AP. So the AP is just like kind of like a KUB. But again, you have to pay attention. Are we just doing an upper GI for the stomach, or does it include a small bowel? So if it's just a stomach, again, small film. Small film, small image receptor at the level of L1. Okay, level of L1, and then midway between the mid-sagittal plane and the left lateral margin. For just the stomach. Now, if the small bowel is included, you're basically just going to do a high KUB. You guys already know how to do a KUB, right? So, mid-sagittal plane, okay, I said high KUB, so center 2 inches above the crest on a 14 by 17. And then there's the alternative Trendelenburg to visualize a hiatal hernia. You do a hiatal hernia, you're going to put them in a Trendelenburg position, because if they have a hiatal hernia, you can see the stomach just go right up the diaphragm. Okay. So the entire stomach is filled up with buried in the fundus. Okay. We already did this, so you guys can look at this on your own. Okay, so post-exam, so we've already covered this. What I want to talk about now is the post-exam instructions. So after they're done with their procedure, the instructions that you're going to get, so you're gonna get them dressed. You're also gonna be nice and clean around their mouths. Okay, we don't want them leaving the department with white stuff around their face. Okay. So what you're gonna tell them now is, Miss Jones, we need you to drink plenty of water for the next 2 to 3 days. Okay? And then you can say, as long as it's fluid, it doesn't have to be water. You like juice, drink juice. You like beer, drink beer. Okay? Whatever their preference is, just make sure that they drink plenty of fluids and they get that and they understand that. You also got to let them know not to be alarmed if their stool is white. It's going to appear white for the next couple of days and will go back to normal color.